Okay, hi everyone. Thanks for joining us. I'm just adding a few more members of the advisory council in. I think we have mostly a pretty remote crowd. For those of you that are joining remotely, apologies that you're kind of looking at the back of some of our heads. I'm not sure what's happening with the camera in the room. Maybe as Kyle is speaking, we can shift around or something. Kyle, I saw that you are on, and I think I've made you a presenter. I just wanted to double check that you can hear us and that we can hear you.
I am here. Yes, hopefully that is, you can hear me and that's working. So.
Yes, you sound great. Wonderful. Well, I would love to just jump in and get us started then, especially want to be respectful of our guest speakers' time. So welcome everyone to this meeting of the Advisory Council on Affordable Healthcare. Our very first agenda item is to hear from Kyle Brown, who is currently a member of Colorado's General Assembly since 2023. And before that had more than a decade of working in the executive branch and in health policy in Colorado, including most recently as Deputy Commissioner for Affordability Programs in the Division of Insurance. So I know we heard a little bit at a high level from Maureen Hensley Quinn from NASHP at our last meeting about all the various work that Colorado is doing on healthcare affordability and multiple dimensions of that for consumers. And it was the top voted item for follow-up or topic for follow-up that I think members of the group are really interested to get to hear a little bit more and engage a little bit about how Colorado developed those policies and how that work has been unfolding as it's been implemented. So I will pause there, and Kyle's going to give us a little bit more of an in-depth overview, and then we'll pause and be able to ask some questions. So I'll hand it over to you there, Kyle.
Thanks, Meg. And it's a pleasure to be with you. And hopefully my internet holds up. It's been a little spotty today. Sometimes these things happen. I'm going to go ahead and try to share my screen, and hopefully that will work. Hang on just a second. Oh.
You should have permission, but if you have any trouble.
Yeah, I will. Oh, wait, here we go. Share content.
It's always hard that we use Teams instead of Zoom.
Yeah, I should have prepared for Teams. For some reason, Teams is not doesn't always work for me. I don't know why. Let's see. Hang on.
Just let me know if you do want to shoot over slides to me. I can also pull them up.
I might. I have. I can't share my screen unless I quit and reopen Microsoft Teams for some reason.
21 years.
Sorry.
Okay. Do you want to just send them to me via email then, and maybe I can open up the slides and control them, or if you want to take a second. Oh. Maybe he's already joining. Oh, thank you, Jordan. Yeah.
Yeah, I could have done that, but no, I like watching.
Yeah. I think you heard someone talking out in the hall.
Oh.
Okay, just bear with us. Always have to have some little tech issue to start every meeting lately, it seems like. I'll just cross my fingers that we don't have another power cut and lose everyone like we did at the last meeting.
Teams is weird for people.
Yeah.
Oh, or this was his vacation.
Wait, presentation.
Okay. Let me just get you added back in as a presenter, Kyle. Bear with me for 1 second.
Okay, let's try this again. There we go. Okay.
Okay, great.
So let me just go ahead and,
Scientist.
oh geez, come on. Watch out. Okay, well, I apologize for the false start there. Thanks for hanging with me there.
No problem. Totally
Um,
understand.
So I wanted to, as Meg mentioned, I'm Kyle Brown. I am a current member of the General Assembly in Colorado. In my former life, I was a deputy commissioner for affordability programs at the Division of Insurance. And in Colorado, the Division of Insurance has been kind of the hub in a lot of really important affordability work that's been going on, whether it's a public option or a prescription drug affordability board, reinsurance, or some other programs. And so today, what I'd like to do with you all is kind of give you a little bit of an overview of what Colorado and its healthcare market looks like, and then talk about 4 key affordability programs that we've put into place over the last 5 years. And I'll start with our reinsurance program, our program that provides state subsidies, which we call our Health Insurance Affordability Enterprise. I'll then talk about our public option program and our prescription drug affordability board. So Meg already told you a little bit about my background, so I won't belabor that, but I've been working in state government now for a little over 10 years, and have had an opportunity both in the governor's office and in 2 different state agencies to be involved in some interesting work. So I hope to share some of that with you today. I thought it would be helpful to at least start with what does Colorado look like, because every state is a snowflake. Every state has its own particularities, and certainly the conditions in Colorado have helped to drive the kinds of policy outcomes that we have seen over the last 5 years. So this is Colorado. It's a very big state. It's the 8th largest by land area in the country. And we have about 5.84 million people. But I think it's important to note that 3 million of those people live in this little bitty circle right here. So there's large swaths of Colorado that are very rural, frontier even. We have lots of access to care issues in these rural parts of Colorado. And actually, to be even broader, about 4.5, I think, million people live between that Fort Collins and Colorado Springs corridor there. So the Front Range is really where everybody lives, except for, 1.5 million or so people. And so you've got, in order to draw congressional districts, you have to basically draw the entire western Colorado, as well as part of Pueblo, in order to get enough people to qualify. So that's just a little bit about sort of where we're coming from. So as I mentioned, that's our population. We are, predominantly white in terms of our racial demographics. We have about 22.5% Hispanic, and we're about 4% Black. Our Medicaid enrollment is about 1.2 million people, which is about 20% of the covered lives. Medicare enrollment is a little bit less than that, at about 13.4%. Commercial market makes up about 50% of all of the insurance, or everybody. It covers about 50% of Coloradans, and our uninsured rate is about 6%. And it's been holding at about 6% pretty steadily, really, since we expanded Medicaid back in mid 2000, around 2014, 2015. In terms of our kind of healthcare market, we have a fairly competitive insurance market. Our individual market is comprised of 6 different companies. We have a United subsidiary, Anthem, which is our Blue Cross Blue Shield affiliate, Kaiser, Cigna, and then 2 other health plans that are associated with health systems. Our small group is essentially dominated by 3 different companies, and they are divided into 2 different subsidiaries. So it's United, Anthem, and Kaiser. Our health systems, we have 6 different dominant health systems, and many of our local markets are very consolidated, especially in areas like southwestern Colorado, where, in Durango, which many of you may have heard of, there's one hospital in that area, and it's affiliated with one of these dominant health systems. So recently they had a contract dispute with Anthem, and our major, Anthem is our biggest. They are the only carrier that is statewide on the individual market, and for them to be potentially falling out of network with the only hospital system in that area was a significant problem for us. We do have over 100 hospitals and 30 critical access hospitals, so that speaks to sort of the rural nature of Colorado. And just for your sort of overall market understanding, hospitals in Colorado, there's been a lot of talk about the payment rates that hospitals receive. And according to RAND and some other data, the most recent data from RAND, indicates that hospitals get about 289% of Medicare in Colorado. Our doctors and other professional reimbursement rates are at about 180% of Medicare. And our payment to cost ratios in the Medicaid program is about 81%. That has climbed steadily since we instituted a provider fee or provider tax on hospitals back in right around 2009. And our Medicare payment to cost ratio has always hovered in the low 70s. So it just gives you a perspective of sort of who's paying for what and how much in Colorado. So the background on our reinsurance program is since the start of the ACA, we've had some pretty high insurance rates. And at one point, Colorado had some of the highest insurance rates in the country. And it was related to a couple of different counties that are associated with ski resorts and our kind of resort communities up in Summit County, if you're familiar with Vail or Breckenridge. These communities had some of the highest rates in the country. And so for a while, we tried to redraw our lines, but the real advantage came for us when we were able to get through a reinsurance program in 2019. And I bring up our reinsurance program because it's a little bit unique in that we divide it based on regions. So that red region that you see on your screen is the western part of the state. And that has traditionally had some of the highest rates in the entire state. And so the reinsurance program is structured in a way to provide some of the best premium savings in those areas because they have, in some cases, premiums on the individual market that exceed the metro area by 30-40%. So you can see down in the right-hand corner there where we've structured the program such that the co-insurance in between the attachment point and the cap varies by region, and it's much higher in this third tier, which helps to provide additional savings from the reinsurance program. So that's one way that we've been able to achieve a pretty consistently about a 20% reduction statewide in the overall individual market premium since the advent of this program. In 2020, the year after we passed our reinsurance program, we remade the program a little bit in a couple of ways, and we've now added state subsidies through this bill, Senate Bill 2215. The legislation created what we call the Health Insurance Affordability Enterprise, and this, at the time, the health insurer tax at the federal level was rolling off, and so it was an opportunity for advocates and for the state government to think about, if we replaced this with a similar fee at the state level, what could we do with it? And so we used this fee revenue, or it's what other states might call a tax, to create a sustainability funding, excuse me, to create sustainable funding for our reinsurance program. And it also provides additional funding for new state subsidies. So there's about $90 million in any given year that's designated for the reinsurance program. Everything that we collect above that is designated for state subsidies. We provide a CSR app for eligible individuals under 250% of poverty. And we also created a new subsidy program for folks who are not eligible for federal subsidies, who don't qualify for APTC. And this is through what we call our Omni Salud program. So folks who are under 150% of the poverty level receive a 94% AV product with a $0 premium. But the catch is that we have to cap enrollment because there is more. There are still about 300 to 400,000 uninsured people in Colorado, and the demand for this program is more than we have funding for at this point. But that's where the public option comes in. And as we've been working on the public option, one of the goals of this was to expand access to affordable health care in different ways, and by using some federal savings to fund additional subsidies. The Colorado Option Program, which is our version, or what we call our public option program, is really based in its three parts. Colorado, before the passage of the Colorado option, did not have a standard plan. And so it's based around a standard plan that all insurance companies on the individual and small group market must offer everywhere that they offer insurance. This plan is, of course, like other standard plans in other states, designed by the Division of Insurance with pretty significant input from stakeholders across the state. These plans that are offered by insurance companies have to be offered at a particular premium, based on 2021 rates. So carriers over the next 3 years have been working to reduce their premiums by 15% compared with 2021. And then we use the federal savings through a 1332 waiver to expand access to quality affordable coverage. And that's where we put it back into the state subsidy program to offer additional opportunities for people to sign up for those state subsidies, both the CSR wrap for exchange eligible people, as well as the Omni Salud program for folks that are not eligible for federal subsidies. So we built our standard plans with health equity in mind, and this was something that the legislature put into the original enabling legislation, that we had to design these plans around the needs that would help to promote health equity. And so we really focused on value-based services, particularly preventive care. So, $0 preventive care for $0 mental health, office visits, $0 perinatal care. We've got diabetes-related equipment like continuous glucose monitors for $0, and then a $5 nutrition counseling. Because the idea, of course, was when we looked at our data with our public health department, we noticed that health equity, that diabetes in particular, was a significant issue for health equity, and so we designed the program around addressing some of those issues. I talked about the premium reduction targets that are inherent in the legislation. And, for the next 3 years, these sort of step down relative to what the rates were when the bill was passed in 2021. And again, the idea is to reduce it by 15% over 3 years. But there are some corrections. So it's worth mentioning that the way the calculations work, you pick the 2021 baseline plan in a given county for a given carrier, And then you have to make adjustments for differences between the actuarial value, between induced demand factors that existed then versus now, some of the CSR loading. We changed our essential health benefits package in the meantime. And so we make a bunch of adjustments, and then we come out with what your premium target is based on that. So this is the methodology that we've come up with. It sounds very simple to say 5, 10, 15% over the next 3 years. But there is actually a lot of sort of actuarial work that goes on in setting these targets. And as I mentioned, they are county and carrier specific, and even, I should say, even metal tier specific. So you might ask, well, great, Kyle, what happens if you can't meet the targets? It's nice to meet a target, but what ability do you have to really enforce those? So starting this plan year, the commissioner can hold public hearings prior to the approval of carriers' final rates concerning the reasons for the carrier's inability to meet the reduction requirements. And this is where the commissioner can pull in not only the carrier, but all of the entities that they contract with. So the hospitals and the providers, with the exception of the pharmaceutical companies. The bill is not set up to pull those folks in, because that is something that states have difficulty regulating. Although I'll get to how Colorado is trying to deal with the prescription drug affordability problem in my coming slides here. But you present all of the evidence about what the reimbursement rates are, and what the premiums that have been submitted are, and based on that evidence, the commissioner can either decide there's nothing that we can do, or he may decide that it is particular reimbursement rates from particular providers that are driving the premium and are causing the carrier to miss the target, and then excuse me, he can impose a reimbursement rate for those contracts between the carrier and the hospital or other providers. And the reimbursement rates, there are protections for the providers within the bill, and that the reimbursement rates have to be equal to or greater than the minimum rates that are specified in law. And so what are those minimum rates? What is the sort of floor below which the commissioner cannot lower the reimbursement rates? Well, for non-facility providers and non-hospital facilities, it's pretty simple. It's just a 135% of Medicare. And mostly that was set up because in Colorado, at least at the time of the passage of the bill, the understanding was that most of the savings, most of the challenge in terms of price and cost was on the hospital side. For hospitals, there's actually a fairly complicated formula that tries to not only establish a base rate, but give incentives for policy choices that the state is interested in. So, you start with a base rate of about 155% of the hospital's Medicare rate, and then you can increase that floor based on whether it's an independent or an essential access, which is Colorado's version of a critical access hospital. You can increase it up to 30% for having a high share of Medicaid and Medicare patients. So this is, again, sort of safety net hospitals get a higher floor and more protection from some of the reimbursement rates that the commissioner might be setting. And then you can get up to a 40% increase for the management of the underlying costs of care. So are you controlling your prices? Are you controlling the cost? And are you controlling your margins? That's what the 40%. Every hospital in the state has a specific reimbursement floor that has to be calculated. And that's what this is, essentially. This is not every hospital in the state, but you can see a listing of all the hospitals. Some of these are urban, some of these are rural. Some of them are pretty low, like Parker, which is down south of Denver, it's at 165, and some of our, independent critical access hospital like Pioneers just below it, is the floor, the minimum reimbursement rate that the commissioner could set should it go to a hearing, would be 223% of Medicare. So you've created the system where you've got a standard plan, you've created the premiums, required the premiums to be at certain rates. If they don't hit those rates, then the commissioner can come in and set reimbursement rates. There are savings associated with that, and particularly savings for the federal government. And so, from the actuarial report, the 1332 waiver submission before when that was eventually approved, here are some of the projected savings over the next several years. It starts out smaller, but as the savings, you ratchet down the savings from 5 to 10 to 15%, and presumably other insurance continues to go up, the savings gradually ratchet up, and those dollars go back into the state subsidy program. So just as a little background on how this all is working currently, because it's been implemented now for about a little over 2 years now. In the first enrollment, or a little less than 2 years, I should say, the first year of enrollment yielded about 35 members. I've broken out the enrollment here into the 25,000 and the 10, because the 10 is the undocumented potentially, or the folks who are not eligible for federal subsidies. That's the Omni-Salute program that is capped. The 25,000 is not. So in 2023, we saw about 35,000 total enrollees, and in 2024, 80,000 enrolled through the exchange, and another 11,000 enrolled through the Omni-Salute program. So the Colorado option plans now make up a little more than a third of our overall individual market. In 2024, the hearings that the commissioner held resulted in 73 contracts being reduced to the statutory reimbursement rate minimum, and 25 individual market plans and 24 small group plans ended up meeting their 10% reduction target. And overall, we reduced the second lowest cost silver plan by about 4.7%. It's not that the rates didn't go up, they still went up, but they went up on Colorado option plans significantly less than they did overall, than they did for the overall individual market. And this resulted in a total pass-through for our combined reinsurance and public option waiver at about $245 million. So I'm going to switch gears just a little bit. I mentioned that prescription drug affordability is particularly challenging for states to work on because this is often regulated at the federal level, and you run into some challenges related to the Commerce Clause and the dormant Commerce Clause. But a number of states, Colorado included, have adopted a model called a Prescription Drug Affordability Board that we hope is going to help us to control prescription drug costs. So what does the Prescription Drug Affordability Board look like in Colorado? Well, in 2021, the same year that we passed the Colorado option, the public option, we created the Prescription Drug Affordability Board. It's a 5-member board, which helps to review the affordability of prescription drugs. And importantly, it sets upper payment limits on unaffordable drugs. So this authority for the board is currently limited to branded drugs that are $30,000 more per month, or for a course of treatment, or has increased in price by 10% or more. There's also authority for biologics and generics, which are reviewed based on different standards. Now, we updated this standard a couple years ago, or I should say last year, so the standards in 2025 will change a bit to be a little bit more, a little broader, I would say. In the Prescription Drug Affordability Board's work is really kind of 4 steps. based on the statute, there's only so many drugs that can be reviewed for affordability and a potential upper payment limit. So the first step is to collect enough data, wholesale acquisition prices, and other aspects that would identify all of the drugs that sort of meet the statutory criteria. The second step is to then, for the board to then look at the drugs and select them for affordability review based on other criteria. So they have to consider what the acquisition costs are, or what the out-of-pocket expenses are, and they have to think about what the input from the advisory board that is supposed to advise the work of the board. They then conduct the review and determine whether a drug is unaffordable. This, again, they're looking at the cost, the access, the impact on safety net providers, input from patients, and other factors. And then they, after that, can set an upper payment limit on unaffordable drugs in rule. So what are these upper payment limits and how do they work? The board, based on the statute, can set up to 18 upper payment limits per year. And they can include multiple national drug codes in those upper payment limits, because the original version of the legislation didn't make this important distinction. But there are many different formulations for the same drug, and so there was questions about whether you can set one upper payment limit applies to just one formulation or one dosage, or whether it applies to all dosage. So we clarified that a couple years ago. The methodology for the UPLs has to be determined by rule, and has to consider the cost of administration and the distribution and other relevant costs, and also whether the drug is in shortage. And then, importantly, these UPLs that are set apply to all purchases of and payer reimbursements for the prescription drug that is dispensed, administered to individuals. So it's really meant to be, a situation where nobody in Colorado should be paying more, including, corporate interests should be paying more for these drugs than the upper payment limit that is established. So the progress here is, methodical, I would say. The eligible drug dashboard has been developed, so we know what the universe of drugs is right now. The board has conducted 3 affordability reviews to date on Trikafta, Enbrel, and Genvoya, and the board has determined that Enbrel to be unaffordable. There are 2 additional reviews that are in draft that are being considered by the board, but no upper payment limits have been set to date. So I've talked a lot, but I want to just mention that Colorado has implemented several important and I think successful affordability programs in the commercial market. We've got a reinsurance program that's lowered individual market premiums by 20% statewide. We've got state subsidies that have provided tens of thousands of folks who are CSR eligible with additional assistance, and provided these $0 premium plans to folks who don't qualify for other federal subsidies. The Colorado option is, has been very successful in penetrating the individual market and is saving people money. And those savings are then being funneled back into the state subsidy program. And the prescription drug affordability work has completed 3 affordability reviews and has determined at least one of them is unaffordable, and as it is moving forward with potentially setting upper payment limits. So with that, I'll just open it up to questions, and would be happy to discuss any of the things that I talked about. So.
Amazing, Kyle. Thank you for sharing. It's definitely a very impressive amount of work that's been accomplished in Colorado. I'm sure there's lots of questions. I have a few, but I did see, Katie, that you had your hand up earlier in the presentation. So I'll hand it to Katie and then to Trish, if that works okay. Go
Thanks so much. Very interesting presentation and really appreciate it. I'm Katie Fulham Harris from Maine Health, which is a health system here in the state. And for your reinsurance program, you mentioned that the reinsurance fund is funded through a tax on insurers. The question I have is, are TPAs included as well? So is it self-funded plans as well?
It is not. We only have jurisdiction. I mean, I'm going to be a little bit imprecise here, but to a first approximation, states do not have the ability to regulate self-funded plans. Now, some of the decisions like Rutledge have kind of changed the legal landscape a bit, but we still have, I mean, we don't even know the precise number of lives, of covered lives in Colorado on self-funded plans. So while we may be able to register to do things like TPA registration, we have not imposed a fee on the lives that are covered under ERISA plans.
Thanks for the clarification. I just thought I'd briefly call out because I know we heard from Colin. I think it's a similar policy as New Mexico instituted, that when that federal tax on insurers was repealed, the state decided to go in. So I just wanted to draw that connection because it was something we had talked about a little bit in the last meeting. So I'll hand it to Trish though next. And then I think Trevor's hand after that, and then Mallory.
Hi, Carl, Trish Riley. You've made incredible progress, and I'm always intrigued by subsidy efforts bring affordability, but they don't lower costs. So I think your 1332 is pretty intriguing, as is the PDAP. I've spent a little bit too much time with lawyers on PDAP issues. And I'm intrigued about, have you had legal challenges to this, A, and B, although the Medicare negotiations on pricing is nascent at best, has Colorado given any thought to reference pricing with Medicare? Should they succeed in lowering their costs?
Yeah, so that's a good question. So on the PDAB front, I think we all anticipate that there will be legal challenges. Those have not come to date because the board has not set an upper payment limit. But I anticipate, and this is just Kyle Brown talking, but I anticipate that there will be legal challenges, formal legal challenges, when the board initiates its first upper payment limit. And I actually think that Colorado will be the test case here, because our PDAB is, we weren't the first PDAB by any stretch, but I think we have accelerated the work at a much faster clip, and we have quickly overtaken other states in terms of the work. So yeah, I anticipate that there will be legal challenges. I don't know what the outcome of those will be. On the reference-based pricing, the Colorado options floors, the sort of reimbursement floors, are reference-based, right? So it's a blended inpatient and outpatient rate. That, you know, the idea is to give insurers and providers the flexibility to work out an arrangement or individual, you know, reimbursements for individual codes or whatever, you know, with it under this kind of floor, and then use our actuarial, you know, engine in the division to verify that those floors have been met, or that the reimbursement rates have met the commissioner's, you know, rate setting authority. So reference-based pricing, I think, is something that we will continue to be interested in Colorado.
If Medicare succeeds in price negotiation, it would eliminate.
Oh, you're talking about on the prescription drug side. Oh, I'm sorry.
On the PDAP. And
Yeah,
so if Medicare succeeds in lowering prescription rates on the drugs they're negotiating, could the state just use reference pricing and apply the same?
Yeah, that's an interesting point. I don't know that we've explored that, but it's an interesting idea. Yeah, I'm sorry. When you said reference pricing,
Sorry. I wasn't clear. And ERISA is every roadblock to innovative state action, right? That's that bill. That's that law.
We would
just-
love to have authority over ERISA plans, but
Yeah.
it's what it is. So,
Yeah, it would certainly make life and work
Sure would.
in some ways easier, though. Understand the patchwork might be a challenge. I was just going to note, I think if I'm remembering correctly, that Enbrel, which was the selection by the PDAB in Colorado for review, is on the list of the Medicare drugs. So there's definitely some synergy there. It just is.
So if they actually do it, states could pick it up with a PDAB-like function.
Okay, Trevor.
Great, thank you. I'm Trevor Putnaki from the Healthcare Purchaser Alliance of Maine. My question is also about the PDAB. We had these conversations here in Maine, and I'm having trouble wrapping my head around how it works if you can't force the manufacturer to sell at a specific price, but you're mandating that employers can't purchase it above a certain price. Is the choice for employers to either not buy the drug or to break the law? I mean, is that where the legal challenges are going to come? Do you have any idea how this is going to sort itself out?
I think the legal challenges will probably be around the authority of states to do this. I think there will be less, but I'm no lawyer, but that would be my anticipation. Like it would be some sort of a commerce clause kind of federal preemption issue. But, I'm sure the industry probably will try to take this down in any way that they want to, and then any way that they can. I think it's not just about like, do employers or do individuals, are they faced with potentially breaking the law or not? It's really about are these prescription drug companies going to say, well, we can't sell our drug legally to an insurance company or anybody else in Colorado, so we're just not going to sell in Colorado. And that's been the sort of bluff, I would say, by a number of insurance companies, by pharmaceutical manufacturers. I don't think that there would be a scenario where the PDAB would set a rate that was where the manufacturer wasn't still able to make a lot of money. So it strikes me that I can only imagine that they will, we're basically saying it needs to be more affordable, and it's not. But I still anticipate that they would continue to sell the drug within our borders at the prices that are set. So,
but the upper payment limit says they can't sell it at beyond a certain price, or that insurers can't pay for it above a certain price.
That one. Yeah, we can't really touch what they sell it for in other places. But we can say that you can't buy this at anything less than anything more than a certain rate.
So they wouldn't necessarily have to stop selling the drug. They could just sell it at whatever price, and then it would be.
But then no one would buy it, right?
Then no one can buy it. Yeah.
Yeah.
Yeah. I mean, I'm supportive of regulating these drug costs for sure. I just am having trouble understanding how this functionally works.
It's a challenging situation, right? Because of the federal government, with the exception of the Medicare negotiation, the federal government hasn't really tackled this issue in a meaningful way, and so states are now striking out on their own over the last several years, trying to do something that's allowable. And so far, this is the best thing that we got. So.
Fair enough. Thank you.
Thanks for that. Definitely been a topic of a lot of conversation and interest here. It's come up in our legislature a few times. Great. Mallory, do you want to ask your question next? And then Jeff, I see you have your hand up, so we'll go to you after Mallory.
Yes, thank you, Kyle. This has been really interesting presentation. My name is Mallory Shaughnessy, and I'm Executive Director currently at the Alliance for Addiction and Mental Health Services, which are statewide providers of those services. When you talked about the minimum reimbursement rate being tied to the Medicare, and you talked about non-facility, non-hospital rates tied, I think it was 135% of the Medicare rate. What about all the services that are not offered through Medicare? When you get into the behavioral health realm, mental health, substance use, there's still a lot of services that really aren't part of the Medicare system of care.
Right.
So what is the minimum? How do you set those and negotiate those reimbursement rates, and what a floor is for that?
That's a really good question, Mallory. The nice thing about Medicare is that even for services that they don't typically or traditionally cover, they actually set a rate. Now, there's arguments about whether that's an appropriate rate or not, but they have a rate for like vaginal delivery of of birth, right? And there's not a ton of Medicare recipients that give birth. Let's just put it that way, right? So I think to your point, even if they don't cover something, it's covered in their codes, and then we can, and then at least we have some sort of reference. But really, what's driving when you calculate these sort of aggregated Medicare reimbursement rates, the volume of services drives the overall average. Right? It's a weighted average, and so the bulk of the cost is in things that Medicare does cover, and so it is easier to, or I think it's a relevant place. All of these things are kind of imperfect in their own way, right? Medicare reimbursement rates are set based on honestly on politics that are set at the federal level, right? But it's the best national standard that we have, and so that's why we've chosen that, and we've tried to, some of the adjustments for different types of hospitals or the kind of work that hospitals are doing is supposed to kind of reflect some of the imperfections in that Medicare system.
Okay, thanks.
Sure.
Jeff, did you have a question?
Oh, Jeff, I don't think we can hear you.
Now,
Yeah, now we can hear you.
all right. That's what I get for roaming around today. So, again, Kyle, thanks. Great presentation. And I'm Jeff Sanford. I work for Northern Light Health, one of the other larger health systems in the state. I have two questions, one super simple and one really kind of a follow-up on Trevor's question. So the first simple question, and you may not know the answer, which is I'm curious as to what the tax rate, for lack of a better word, you have for the reinsurance, whether it's a per member per month or per member per year. If you sort of roughly know that number, I think that'd be interesting for those of us in Maine that fool around with MGARA and understand how that works. I was kind of curious. So if you got a number, toss it out there. If you don't, that's fine.
Yeah, and I'll have Jeff. I'll have to get back to you on the exact numbers because there's a different rate for-profit health insurers versus the nonprofit health insurers that was negotiated during the original bill.
Yeah,
but in the for-profits pay about 2.25% of their gross premium, I think.
Okay.
It's structured kind of like a premium tax, and then the nonprofits pay less. They pay like 1.5, I think. So Kaiser is very big in our market, and so they got a special rate because they have a different model and we do different things for Kaiser sometimes. Okay. That's the way it's structured. It's structured as here's all the premium we took in for all of our fully insured market, and then we pay a percentage off of that.
Great. I'm going to go back and tag on to Trevor's question because it's an interesting one about. So you set an upper payment limit that the payers can pay, right? And so kind of follow up to Trevor's point, which was, well, so what? if I'm let's say I'm a ambulatory care provider and I'm doing infusion drug therapy on an outpatient basis, and I'm the one that is not going to get paid what I got paid before. So I may choose to not prescribe and deliver that infusion therapy, or I may have to go to an alternative, right? So that's where this question about I know what you're trying to do. I don't know what the answer is in order, how do you get to big pharma? Because it seems like, and I think we talked about a similar program the last time we met, where at the end of the day, I'm going to say it falls upon one of the middlemen, the provider or pharmacist or pharmacy, or even a inpatient hospital that's delivering something, through inpatient therapy, and ultimately does not end up back with the pharmaceutical companies. And maybe that wasn't a question, maybe that was a statement.
Yeah, no, I get it. I think I get what you're saying. I think in some ways it is meant to, especially for branded drugs, right, where there's no generic equivalent yet. I think part of the hope is that it changes the negotiation dynamics between insurance companies and the manufacturers. If they can't pay, if they literally are not allowed to pay more than X amount for a drug, then is GSK or Pfizer gonna say, sorry, Anthem of Colorado, with all of your gazillion lives, are you just not gonna sell them drugs anymore? Or are they going to say, yeah, we'll sell you drugs and we have to sell it to you for less, right? And so I think we haven't seen this play out yet because we don't have an upper payment limit. From the very beginning, the pharmaceutical companies have fought the implementation of this. Unlike the Colorado option, where we were able to come to some agreement with at least some of the insurance companies and some of the hospitals, none of the pharmaceutical companies came to play on this one. So they continue to oppose and fight. But we've also gotten in a situation, we had a situation with the Trikafta recently, where the company was, threatening to leave if we set an upper payment limit. Now, we didn't end up determining that it was unaffordable. But I always thought, like, is a company really going to say, sorry, we're not going to sell our drugs there anymore? Like, we'd prefer to make no money as opposed to less. I didn't think that was a reasonable thing for them to be claiming. So I could stand corrected, and if that is what happens, then I'm sure there'll be different conversations about whether or not this is an appropriate mechanism. But the prices, nobody would argue that pharmaceutical prices are appropriate at the end of the day, and that's sort of what we're trying to get at.
Renee, I do see your hand up, but just briefly,
Well,
Trish,
just
if
to
you wanted
follow,
to.
I think, Kyle, isn't some of the thinking, my memory is bad on some of these issues, but the thinking was a pharmaceutical, there are some guardrails through insurance formulary requirements and through Medicare, that if these drugs are on the Medicare formulary, a drug company is not going to stop providing coverage. And it's so much more complicated for a company to make a decision to tweak a formulary for 2 or 3 drugs that it uses nationally, especially the Medicare program.
Yeah, I think there's a lot of things like that it's a very dynamic and complicated market, right? And there's lots of different purchasers of drugs. And each one of them negotiates their own prices to some degree. So we're a ways yet from seeing the full implementation of our PDAB, but but we're getting there. So.
Yeah, I like your framing as a test case. I think definitely we'll be watching along with a lot of other states to see how that plays out.
Yeah.
Renee, I saw that you have your hand up. We have just a couple minutes left, but I think we can fit in one more question.
Hi, thanks. So I actually have two questions, but I'll start with one and see if we have time for the other. So I'm Renee Fay LeBlanc, and I am a physician at an FQHC here in Maine. And I'm wondering how these programs and the payment arrangements have affected FQHCs in Colorado, because, you know, with Medicare and Medicaid, historically, we get different rates. And so wondering how that's factored into these programs.
Yeah, that's a good question, Renee. Now, I think for when you're talking about reinsurance, something like that, or the state subsidy program, those programs really focus on expanding access to coverage. And so, while I'm not from the FQ community here in Colorado, anytime we can get more people into coverage, especially with commercial insurance, that's generally good for safety net providers. Our safety net hospital in Denver is always happy to get a commercial patient. On the other side, you know, for the Colorado option, the rate setting authority does technically apply to things like FQs, which we treat, I think, from a regulatory perspective, a lot like just doctor's offices. But we all know that FQs are not the problem that's creating the unaffordable premiums. And so part of the hearing process is about kind of determining who's responsible. Is it insurance company profits? Is it some hospital system charging too much? And I don't think anyone thinks in Colorado, the commissioner included, that the FQs are an issue here. And so they, if anything, the Colorado option, one of the provisions within it is that we expanded, there's a federal requirement about the percentage of essential community providers that you have to have in your network. And it's like 30%-ish from a federal requirement. In the Colorado option, we require the plans to have 50% of their essential community providers. So we're requiring the networks of these plans to include more safety net providers, and that, you know, hopefully drives more commercial market utilization to these safety net providers. So that was another aspect of the sort of health equity components. So, you know, I can't say the people who still are upset about the Colorado option are still the major insurance companies, and to some degree the larger health systems. But the FQs, I don't think, have seen. It's, you know, if anything, it may have helped on the margins to them, although it probably hasn't affected them much.
Do you have a hard stop, Kyle? I just want to double check, or do you have time for one more question?
No, I have time for one more question. I just don't want to. I've taken up an hour of your time already, so I don't want to.
No worries. I'll just let Renee ask her second question, and then we can wrap up. Let know if that works.
Yeah, so my second question is just about sort of from the patient perspective, and what has Colorado done to, you know, thinking through an equity lens. You know, sometimes these programs are amazing on paper, but they're just so hard in real life to sign up and, you know, stay enrolled and all of that kind of stuff. So this may be too weedsy, but what is your state done to make sure that these programs can be well utilized by people who, you know, maybe English isn't their first language, maybe they don't have access to a computer, you know, that sort of thing?
That's a really good question. So a lot of these programs are really designed to be pretty back end for a consumer. So the CSR subsidies, the reinsurance program are things that people just, you know, you sign up for insurance through our exchange, and you just get it, right? The Omni Salute program, which sort of sits in a mirror exchange, we set ours. There's kind of historical and political reasons that we had to do it this way, but we set up like a mirror exchange or a partner exchange to offer this product that was accessible to undocumented folks who don't qualify for federal subsidies. That is still a situation where because we can only accept about 10, 11,000 people a year, people have to go in person to sign up. But the people who are doing the enrolling are healthcare navigators that work with particular cultural cultural sensitivities, that work with communities of color, that work with people who where English is not their first language, and they like in my community, the major enrollment site is the FQ for this particular program. So the Division of Insurance actually hired a specific I'll call her like enrollment manager or specialist who works with different communities across the state to try to expand access. And today, that program, or this past year, that program hit its enrollment limit in 2 days, which is kind of sad that we could only have a 2-day enrollment period for something that there is clearly so much need for. But it is, we just don't.
Perfect position.
Kyle, I don't know if you can hear us. We lost you. You froze. Oh, I think you might be back now.
Can you hear me, Meg?
Yeah, we can hear you now.
Oh, okay. Sorry about that. Everything I said that you didn't hear was brilliant, I'm sure. So.
We were saying good timing just as you were wrapping up, and yeah, very really striking to hear that within a couple of days you had completely filled that program. Clearly demonstrates how much of a need there was among that community and that eligibility group for a more affordable option. So just wanted to thank you again for taking time and spending so much time with us to do this deep dive. I think this has been really informative for the group. We'll be discussing a little bit more alongside the work of some other states, so may circle back with a few more questions, but just wanted to thank you again. This was really, really valuable and very much appreciated.
Well, thank you all, and feel free to reach out in the future if I can be helpful.
Great. Thanks again. Have a great rest of your day.
Take care.
Bye. Wonderful. Well, I had budgeted a little bit of time in the agenda just to kind of debrief if there was more conversation. Briefly, I will say looking through the sort of prioritization of other topics, the next two that were sort of most in demand were to follow up with Colin about the Medicaid Forward proposal in New Mexico, and then to connect with the market review folks in Oregon and hear a little bit about that program that Maureen had touched on. So working on setting those up for June, and then I'm hoping to maybe squeeze in a couple more presentations in July. So we'll do those on kind of just a one-off basis and record them. And then my hope is to spend about a half of our agenda for our August meeting kind of debriefing on all these conversations. But I also had a feeling that we might be asking questions right until the end of our time with Kyle. So like I said, just thought I'd pause there in case there was anything that anyone wanted to highlight as something interested in learning more about, questions, observations. Just give us a little time to debrief. Great. Everyone's digesting, yeah. I will say, I think definitely a theme from a couple of the conversations, and not to belabor the point because I think we touched on it, but watching to see how those programs play out. I think it's come up in a few different settings. Some of the questions about, in practical terms, kind of how those programs will operate. So I actually, if we had time, I was going to follow up, but I can double check on it offline. I didn't catch if Kyle had included a timeline for when they expect the first payment limit to go into effect there. I know they're working on rulemaking this summer, but I'm not sure if that would be a 2025 effective or if they'll do it for 26, acknowledging that there will be some work to do to set that up. So I think it's a little ways off, but something certainly I'll be paying attention to. And I will say, I feel like I've spent a lot of time looking at reinsurance programs in other states, but actually either hadn't known or hadn't remembered that they had that regional variation, which is a really interesting concept. You know, one thought that I had was there's some likelihood, right, that maybe you're providing a slightly less premium relief for maybe a large population center, but this idea of kind of, are there populations where it's needed more because it may be a greater affordability barrier, I think is one that's interesting to think about and consider how they might have grappled with there. Okay. If there aren't other kind of comments or briefs, which again, understand everyone's probably digesting a little bit, and we can follow up on that in the next meeting. I think we can move along to the next agenda item that I had for today, which was just to spend a little bit of time talking about and getting your feedback and reflections on some of the other affordability reporting from other states. So really just in the past few months, these reports have been rolling out. Some of them are framed as 2024 reports, but mainly looking at 2022 data because of the turnaround time to do some of the analysis in states. As I mentioned, these reports that I shared, as well as a few others in other states, are all kind of coming out under the auspices, under the structure of cost growth target programs. It may be that there's others in other states not associated with those programs, but I haven't seen them. I'm not aware of them that do this kind of in-depth analysis. In general, I think they've been tied to those programs. So did want to note up front, you know, I'm not suggesting that we would be setting a cost growth target or you know, tracking towards that, but I found that the vast majority of the analysis in those reports, you know, is really valuable and doesn't necessarily need to be tied to cost growth targets. I also noted there was, you know, some variation, while I think there were definitely core metrics and core themes throughout and how those were presented. So one thing Trish and I were actually chatting about before the meeting started was a takeaway from me was Rhode Island's report and how much they kind of provide context, and it's a little bit more of a narrative format as opposed to being just a series of charts. That's something that I really liked about the report. And as I think about future annual reports for the Office of Affordable Healthcare and who I anticipate the audience for those being, you know, policymakers, potentially some who may be more or less familiar with health issues, advocates, members of the public, that was something that really appealed to me. But I know that some of the reports also have, you know, really deep dives in areas like insurance costs or sort of more sophisticated analytics. So I just wanted to hear if anything had jumped out to members of the advisory council. Again, I will say some of this is more aspirational, but we are thinking about the first year, and I'd like to know if there are things that I should really be prioritizing, trying to replicate, or beginning to think about how we could build out as I start that sort of lead up to putting together a draft of the annual report for the end of the year. So I will pause there. Jeff, I see your hand up. Hand it over to you.
Yep. No, thanks, Meg. I had a chance to look at 2 out of the 3 reports. And, you know, what I find helpful is, you know, when the comparative numbers are meaningful, like, you know, per patient or per member, you know, big numbers like, oh, we spent $9 billion. Okay. Is 9 billion a lot or not? Right? I don't know. Massachusetts is probably rounding. You know, for us, it's obviously a big number. So I think to the extent that the report has numbers that people can relate to, right? So, you know, just tossing out really large numbers, I think, is not super helpful. But having numbers that people can relate to, right? It costs, you know, the average family $10,000 a year for healthcare, right? We can all wrap our heads around that. But to say, you know, healthcare costs the state of Maine, you know, whatever the number is, 1.8 billion, right? That doesn't mean anything.
Yep, that's a great point. Totally hear you on that, Jeff. I'm sure to some extent the overall trend numbers, especially for them, are in some part related to the cost growth targets and the sort of global nature of those. But I think doing per capita or per member per month is really helpful, both in terms of how sort of tangible that number is, but also in thinking about, you know, obviously so much of this work is divided out by market type, for example, and in a state like Maine, where maybe we have, a higher percent of our population in Medicare than in commercial plans, for example, it can make a big difference in what those top line numbers look like. So that's a great takeaway. Thank you.
I mean, I thought these reports were really fantastic. There's just a ton of useful data here in one place. I think generally speaking, it's nice to have more years in trend. Some of them I feel like only had maybe 2 or 3 years, and they were really like COVID years, so it's sort of hard to put them in context. So pre-COVID would be helpful. And the payer data was really, really interesting to be able to see what kind of like market share different payers have and what their trends in relation to each other have been, what kind of their spending looks like. I thought the hospital financial data was also really valuable. Getting to see the operating margins and whatnot. I believe that was in the Massachusetts report. Yeah, I mean, it would be amazing to have this kind of data readily available for a state like Maine.
Yeah, definitely. I think Massachusetts by far was
Yeah.
the most in-depth and most expansive. And I know this is, they were really pioneers in this work, so I think have built up to that. But I agree, Trevor, I will say in their report, one of the things that really jumped out to me was the data that they had across their commercial insurance market, which I think is a knowledge gap a little bit for us, which I know has come up in some of our prior conversations when we've tried to talk about, what do premiums look like. It's very hard to do that reaching out to the employer-sponsored market. So that is something I think on a longer lead time, there's only so much we can do with the data that we have, but I'm definitely really interested in exploring whether that's something we could begin to report on more regularly, because I think it's a really valuable contribution to the conversation.
Yeah, those premium breakdowns in particular in the Massachusetts report were really fantastic to see what amount of spend is going to claims versus admin and overhead, taxes, fees, other quality programs, all that kind of stuff. I've never seen that for Maine, but it would be really nice to know.
So I'll pose one particular question that I had. I am meeting towards the end of this month with Maine Health Data Organization, Maine Quality Forum, to work a little bit on kind of planning for our analytic agendas. I will also briefly take the opportunity to say we do have a senior analyst who's going to be starting on the 24th of this month, so that's very exciting. I'll hold off to introduce her until she's onboarded, but planning to really ramp up this work with her on board. And one of the things I'd like to discuss with Karen Lee and her team is quality measures. It's something we had touched on really briefly a few meetings ago, but it came up for me again reviewing these reports and thinking about how other states have selected quality metrics. I was looking at the core ACO quality measures that were in the Rhode Island report in particular, but I did want to take an opportunity, even before I start having some of the conversations with MHDO MQF, just to check and see. I know some of you, especially working on the clinical side, we have a lot of expertise here, I think, in quality metrics. And I'm curious if there are other standard data sets that I should have on my radar and be thinking about potentially wanting to align to. I know my first step and a lot of my focus has been kind of on the spending side to begin with, but I don't want to lose track of thinking about how we measure quality and access alongside that. So that was one topic that I really wanted to get some early thoughts on, even if it's just take a look at this or make sure it's on my radar. It doesn't necessarily need to be the final answer now, but I'd appreciate just making sure that I'm not overlooking something that potentially could be a good resource in thinking about that decision. Yeah, Renee?
So I think of that question, like the quality metric side from a clinical perspective, I have a couple of thoughts. One is that, there are so many things that we're being asked to measure from so many different sources, the federal government, the different insurers, the ACO that you're involved with, everybody's got measures. And so trying to utilize what's already being collected, I think would be helpful, just in terms of like overload from those folks on the, on the ground. But the other thing is, I really struggle with this a lot because a lot of these measures are surrogates for what we think might mean better healthcare, but we don't really have any data to support that. And so it's hard to know. I mean, looking at improving health and decreasing costs takes so many years that, it's a little bit hard. We're incentivizing a lot of check boxes and markers, but I don't think we know if any of that is actually going to help us in the long run. So it's a tough one. But having said that, we're already collecting so much data that it would be great not to reinvent the wheel.
Yep, totally agree with you there. I think both from a provider burden perspective, and I know from some prior work that the quality of the quality metrics, but their reliability can be challenging at times. So my instinct would definitely be to go with what are some measures that have been collected for a while that are pretty standardized, that folks are comfortable with, and with where we feel potentially like there's the best baselines to be able to measure against. So I'm totally with you on that. I'm curious, and I know this is a really hard question, so I don't expect you to have an answer. I totally understand what you're getting at in terms of kind of proxy measures that, a few even clinical outcomes aren't necessarily indicative of kind of overall health. I just wondered if there are any metrics, or if you have thoughts about how to collect that. Again, my guess is the answer is no. I don't know that we'll solve that in this conversation, but I just wanted to double check if there's anything maybe less, traditional, standardized that I should be thinking about.
I don't really have any great really great thoughts about that. I mean, one of the things that I think is possible to measure, and of course, like, nobody's asked us to measure this, so I'm just going against what I just said. But sort of like pharmacy data around whether patients are actually taking the meds they're prescribed the way that they should be and getting their refills, because I think that's, we can do all these things in the office and check all the right tests and all of that, but if the patients leave and they're not filling their scripts, then we're not going to be improving their care. So.
I think I've always been skeptical about consumer satisfaction measures because you can razzle dazzle us consumers easily. But I wonder if there aren't some about timeliness, referrals, sort of things that look at the system that might be less prone to just sort of subjective, the place was clean and pretty.
Yeah, I think the only, I don't disagree with that. I think the only caveat to that is that, so we asked those questions and we were trying to do a little bit of a deeper dive to figure out what people mean. And it's sort of all over the board. When you ask somebody, what do you think is a reasonable time frame to be seen for, an acute problem versus a chronic problem versus a physical, some people it's like 12 hours and other people it's 6 months. It's crazy. So sort of how do you, how do you sort through that kind of feedback if everybody has a different guidepost in terms of what it means to have access?
Unless we start to ask the questions differently and just determine what's the appropriateness measure, how timely should, I don't know, it's awfully hard.
Right, yeah, we could ask, like, if you had an acute problem, were you able to see a provider within, I don't know, whatever time frame, so that it's, more objective than the subjective, could you get in when you wanted to question?
Right, exactly.
Yeah. Jeff, I hesitate. I usually try not to put people on the spot too much, but in particular, just because Rhode Island had been looking at those core ACO metrics, I was curious if those are anything that you've used within Northern Light, or if you have kind of a core set of how you measure quality, particularly kind of in the ACO APM context. I thought that might be just informative to know in thinking about this. Because I did like, I will say, the fact that those core measures have kind of been developed by CMS and others, kind of getting to Renee's point about something that is already established and seems to have been vetted pretty well. But yeah, curious if that's anything that's been taken up here or reviewed and chosen not to take up, Jeff.
Yeah, no, thanks, Meg. We've done, we've been involved in, Medicare ACOs since 2012. And, over the last 12 years, we've learned an awful lot about it. And as others, have noted, over time, you end up with, lots of different metrics, for each payer, some different metrics, some different thresholds and that sort of thing. But we really, focused on outcome measures, in part because that's kind of where the industry was headed. And they're generally more meaningful than, process measures, which you typically get, out of claims data. But what we did a few years ago was we said, all right, we have, I can't remember the number, 200 different quality metrics across all of our payers. And we said, all right, what are the 10 most impactful measures? The ones that cross most of the plans are, and that's a judgment call, right? I mean, some of it's, doing the math, but some of it's like, what are the most impactful measures, for the, patients in the ACO? But we eventually trimmed it down to, these are the 10 measures that we need to drive. And that's really how we sort of trimmed it down and focused on the metrics that we thought made a difference. We still get measured on all those 200, but the ones that we really focus on are those 10.
Awesome. Well, I would love to follow up and shoot you a note if it's something you can share with me, directly. I'd love to take a look at that, just so that I could have it as a point of reference as I'm looking at other lists and see where there's crossover or how to use that as some inspiration.
Yeah, well, I would probably pass you off to our folks that lead those efforts in our quality group, and they would love to talk to you about it.
Okay, great. Yeah, I'd love to do that. And if Katie's still on too, maybe I can follow up. I think getting a sense of what Northern Light and Maine Health are doing would be a good way to just get a feel for, a large number of people and a large kind of population here. So I'm happy to do some one-to-one follow-up after this meeting. Any other comments or thoughts on the recording? I can sort of briefly wrap us up. I will say I mentioned having our senior analyst start. The other place where we've been making some good, strong progress is on the analytics that we've talked about before. So spending reporting, looking at price, utilization, and service intensity, and breaking that out by different market categories, and also looking at some hospital-specific spending data that we're doing with Maine Health Data Organization. So really kind of a next iteration of some of the work that Karen Lee and team had done before the start of the office. So we are hoping, the timeline is very tight for turnaround right now, but I am anticipating and hoping being able to do an initial presentation of those new dashboards at our August meeting. They'll be in draft format and not polished, but I thought it would be helpful to be able to bring those to the group and get feedback or questions as sort of a gut check on those. So it is some exciting progress. As with all things, contracts take a while to work out. And so that was a few months of work, but the work is underway on developing those. So lots of meetings over the next few months on creating those. And that will be a great first step, but I really see those as a little bit more like, not the raw data, they will be in visualizations in Tableau, but it will be a lot of data. So I'm thinking about what's that next turn where we can pull some high level reflections, hopefully out of that, editorialize on them a little bit and think about how to represent them in ways that are informative for policymakers and for others for the annual report. Since it is already June, which is amazing, and time flies by. So that's the kind of anticipated agenda for the next meeting would be to hopefully spend about an hour of the time reviewing those dashboards and discussing, and maybe about an hour, maybe an hour and 15 on dashboards and 45 to kind of reflect on some of the policy presentations and questions or feedback from those. I think that was everything that I had on the agenda. Do any council members have anything that they'd like to raise with the group? Questions from me? Okay, great, everybody. Well, I hope you're enjoying the start of summer. I hope those with kids are enjoying all the concerts and presentations. I'll be going to a celebration of learning tomorrow as school wraps up. And then that summer break, it gets underway well for all of you, and we'll reconvene in August together for our summer meeting. So look forward to seeing you all then.
Thank you.
Thank you all. Bye-bye.